Next up, we have Eric Hall, PhD, MPH. He's an assistant professor of epidemiology at OHSU-PSU School of Public Health, and Eric specializes in infectious diseases and overdose epidemiology and modeling, and has been instrumental in efforts to elevate viral hepatitis, substance use, and overdose on the national agenda. Eric is widely published in multiple journals and online medium and has an active research and teaching portfolio at OHSU.
Hello, everyone. Thank you for that very nice introduction. I'm happy to be here. As mentioned, my name is Eric Hall, and I'm with Oregon Health and Science University. And today I'm going to talk a little bit about an analysis that I did with some colleagues related to the conversation that was really in the news, and I'm sure on a lot of our minds last week and this week related to the Advisory Committee on Immunization Practices infant hepatitis B vaccination schedule. And so I'm not entirely sure what everyone's background is with ACIP in this group. I'm sure some have much more knowledge and experience about how ACIP recommendations impact the way public health plays out here in Oregon than I do, certainly, and others maybe less so. As I'm looking at this, I wish I provided a little bit more context here, but these recommendations have historically been quite important across the country because they essentially, set the recommended federal policy around how vaccines should be used in the United States, and that can directly impact a lot of individual state laws and statutes about a variety of things, things such as what types of funding, insurance, or state dollars cover vaccines, what school requirements might be, scope of practice laws around who can administer vaccines. So historically, these have been very important, and that's why it's been covered so much in the news lately. Um, and I just wanted to talk a little bit about some work that I did with some excellent colleagues over the last couple months around this particular discussion that happened last week. And I, put up this slide just because I wanted to highlight this team that I worked with and some of the people in particular, with the main point being everyone in this group has previous experience, either working closely with previous iterations of ACIP, leading work groups. In the case of Dr. Noelle Nelson, many of you who are in the hepatitis B prevention world are probably familiar with, either know her or know her name. She literally was the senior author on previous versions of these national recommendations and policies. So this is really an expert in this field here, or others such as Dr. Prabhu Gounder from LA, who's been part of these work groups. I know, Ann Thomas here from Oregon has previously been part of these work groups. And then I've had the opportunity to previously work on modeling studies that were used in ACIP deliberations in the past. And I just want to put that piece out there because that's an important part, I think, in the story. Our involvement in this, I think, is an important part in the story and kind of changes that are happening around the way these national recommendations are coming to place and I think eventually being used. And so my team initially became interested in this particular conversation because I'm sure as many of y'all noticed or remember, this group met previously in September earlier this year, and at that point began at least publicly discussing for the first time changing the recommendations for infant hepatitis B vaccination. So up until that point, from 1991 until last week, there was a universal recommendation to vaccinate all infants shortly after birth. The timing of that recommendation differs a little bit if they were born to a birth parent who is known to have hepatitis B versus if they were not known or had tested negative. But in general, it was a universal infant vaccination recommendation. And so in September, this group started having conversations about potentially changing that. And the four of us were all paying attention and very interested. And we quickly noticed that this committee did not have many of the key pieces of evidence that they historically use to evaluate such important decisions. There were a variety of things we and many other people noticed, and a variety of problematic things about which the way they were going about their business. But a very obvious one was that they were not using all the pieces of information that they typically use or historically have used for this type of consideration. Historically, ACIP has used something known as the Evidence to Recommendations Framework, which is a very nice framework that evaluates data across a variety of domains. Things like, will this potential policy change, how will it impact health outcomes? What will be the potential benefits? What will be the potential harms? Is this potential policy change an efficient and responsible use of financial resources? Are there implementation considerations that we need to think about? Are there health equity considerations that we need to think about? There's all these very well-defined domains that in the past, when they issue new recommendations or decisions, they then publish all the data and evidence that they evaluated within those domains. Again, at this September meeting, it was very obvious they didn't have the information across these pieces of their framework. And we realized there were a couple here, the potential benefits and harms, and if it's a responsible financial use of financial resources, that we had the skills and expertise to try to fill that evidence gap and at least put that information out there. And it could be considered or not considered. But that was our motivation in September. And so we designed this analysis in the framework of the types of modeling studies that they have historically used and considered in the past. I'm not going to talk a ton about how we did this modeling because I don't know if that's the biggest interest for everyone here in this group, but I do want to highlight a few key things that are important for interpreting our results. So a big part of this discussion around should there be, universal infant vaccination in hepatitis B, or should there be risk-based approach, hinges on our ability to correctly, test and identify the hepatitis B status of pregnant persons, either prenatally or up until the time of delivery. And that's an important part, and that was an important part of the conversation. It differs place to place. We were approaching this from a national perspective, but the fact of the matter is, unfortunately, in the United States, we are not perfect at doing that, right? We all know we have challenges with our healthcare system and prenatal care, and there's a variety of reasons why a pregnancy can arrive at the point of delivery in which we don't know the hepatitis B status of that birth parent. And so we modeled that, we included that in this model because that's an important thing. Again, we're using national data here, have a variety of inputs on that I could talk about later if we wanted. But in our model, we essentially had about 1 in 5 pregnancies arriving to that point of delivery in which we didn't know the status of the birth parent. Another important piece, I'm pretty sure everyone in this group is familiar with hepatitis B transmission, but there is a very substantial risk of an infant acquiring an infection if they are born to a birth parent with hepatitis B, and there is no vaccination or any type of intervention at that point. So we, of course, modeled that risk here. However, something that, believe is underappreciated and not well discussed, especially in the conversation last week, is those infants, even if they don't acquire an infection right there at the birth period, they could potentially face an elevated risk of HPV acquisition through household transmission at home. So we have an input there for that. And then, of course, any unprotected child could face a risk of community transmission, especially as they get a little bit older. And so, these were particularly important and challenging data points for us to include in this or to identify in this model. But these are the risk periods that we quantified here. So we were modeling the number of infections that would occur in childhood across these different policy scenarios that I'll talk about in a second. And then other details of what we did here, we then essentially simulate forward in time these infections through all the variety of different health states of a disease progression, and we include costs for the medical management of disease at these different health states. So this is how we're building up our economic outcomes here. And just to highlight the outcomes that we included in this model here, so we quantified incident acute infections, or estimated that would occur among children up into 18 years of age under these different scenarios, and then the lifetime health complications and costs with those infections. And then we have measures of quantity and quality of life, life years, quality adjusted life years. And then, of course, we can, in this model, we can quantify the number of hepatitis B doses that would be given out and the number of people that would be protected um, with a complete series or greater than or equal to one dose. So that's kind of our structure. We simulate a cohort of infants born in the US forward throughout their lifetime to see how these different vaccination scenarios or assumptions would play out. Now, this would have been a different, conversation if we were having, this discussion at the beginning of last week, because when we began this work, based on the conversation that we observed at the September meeting, it was unclear exactly what policy this committee was considering or how long of a delay they were considering for the infant hepatitis B vaccination schedule. So in our work, we modeled a variety of different scenarios in which vaccination would be delayed either to 2 months, 7 months, 4 years, 12 years. And that's primarily because those are the time points that we had heard had been rumored being considered. The conversations went on last week, and it turned out they were talking about delaying to 2 months. So I think those are the most important results that we have here. But if you are looking through our preprint, you'll see all these different scenarios and all the end results from these different time points as well. It was also unclear if the committee was considering delaying vaccination only among infants born to Hep B surface antigen test negative birth parents, or if they were considering delaying or recommending a delay among those born to test negative parents and status unknown parents. So we included both of those in this model as well. That became a little more clear during the conversations last week, but again, at the time that we started this work, we didn't know what they were considering. And then importantly, I'm not going to go into this into too much detail here, but this is something if I'd be curious to hear thoughts about. There is evidence that the later the vaccination series is started, the fewer number of children that initiate that series and the lower probability that they go ahead to complete the 3-dose series. And so we wanted to try to capture that in some of our modeling scenarios as well. So we built that in a set of scenarios that we called our imperfect adherence to recommendation, in which we allowed for fewer children to start the series as the delay was larger, and then a lower likelihood of completing the series. Now it's very hard to know. It's very hard to predict, right? Like if we delay this out to 2 months, what proportion of children are actually gonna, parents will elect to bring them back and elect to have the series started at that point or not. And it's particularly hard to know when it's pushed out to further years, 7 months, 4 years, 12 years, etc. So we kind of did the best we could in terms of looking at other recommended vaccines around those timeframes to come up with data to use as inputs for those. But these are modeling assumptions that we don't necessarily know exactly how that would play out. In addition to that, we also modeled what if every single child perfectly followed the recommended series? What would that look like? Just to try to get a little clarity around the potential uncertainty that we could be introducing by those imperfect adherence to recommendations. So I know that's kind of a lot. There's lots of results in here. I'm going to direct us towards what ended up being the most relevant ones based on the discussion last week. But I just wanted to set that tone or that scene a little bit in case you are interested and happen to be reading through our preprint of this. So in our paper, this is just a table that shows these different vaccination scenarios that we modeled. I'm not going to go through it, but I wanted to highlight one of them just so, again, if you're looking at it, you have a sense of kind of how to read it. But what ended up being the most relevant scenario that we modeled to the conversations they had last week was our alternative one scenario, which was essentially delaying the first dose to 2 months among those born to test negative hepatitis B surface antigen test negative birth parents. And then keeping the recommendation the same for those born to test positive parents, and then keeping the recommendation the same for those born to birth parents in which we don't know their surface antigen status. And so that's the box that's highlighted here. So you can see in the middle, essentially what we modeled is pushing out the start of this series to 2 months and then continuing the same time frame between doses. So the second dose being at 3 months and then the third dose being at 8 months. The numbers in parentheses underneath, those are the proportion that would receive each dose in our imperfect recommendations adherence scenario. Highlight a couple results. So again, I'm going to go to some better slides to look at results here, but I just wanted to put up this screenshot from our preprint paper and orient you to it in case you want to go and look at some of these results on your own. But this is our primary table of results that has the change in all these different outcomes relative to the previous universal birth dose recommendations. Um, I've highlighted the first column here again because this is the one that ended up aligning most with what they discussed last week. And so taking a look at this, the top half of this table are those scenarios in which we allow fewer children to start and complete the series when it's delayed. And then the bottom half is assuming every single child born in the US in a single year would follow the recommendations perfectly. And so the takeaways here, looking up at the top half, and these will be on the next couple slides, is, our results found that, for the US using national data, delaying to 2 months among births to birth parents that have tested negative for hepatitis B surface antigen, that would result in an additional 238 acute infections, 75 additional chronic infections, 62 hepatitis B related liver deaths, and then our economic outcomes here, an additional $21.5 million in healthcare spending over the lifetime of those infections. And I just want to highlight, again, I can't remember if I mentioned this a few minutes ago, but we only modeled one single annual birth cohort. So these are the outcomes that would occur just among all the infants that would be born in a single year. For each year this recommendation is in place, these outcomes would continue to accrue. And I think, we could have a conversation about this, but I would expect these numbers to go up each year annually as community prevalence probably goes up. Our goal was to get this information out there in advance of the meeting with the hope that it would end up in front of the ACIP committee, although I wasn't convinced it would impact their thinking or decision-making much. It was important to me that they came across it and saw it. And it was also important to us that we got it out to the general public and made it available to any other, whether it's professional societies, states, some of these coalitions of states that might be issuing their own recommendations, that they had this information as well. And so we were able to partner with a couple great organizations, Hepatitis B Foundation, and VHR, on developing these really cool infographics and really trying to share this information far and wide. So this was one of the infographics that was developed. Again, this was developed before the meeting last week. So we have results on here for delaying vaccination across all of our different time points that we modeled. Again, I'll draw your attention to the 2-month delay because that is what they ended up discussing and voting on. And so those are our pink, numbers here. These are the numbers I just told you about new infections and deaths and liver cancer cases. And then of course we see that if that delay would have been recommended further out, we would anticipate those numbers to increase. Here's just another really nice infographic that was put together that focuses on the change in healthcare spending with these policy changes. So again, this is the result that I highlighted from our table, delaying infant vaccination among those born to test negative birth parents. Delaying that 2 months, we modeled would result in additional $21.6 million over, for every year that this recommendation would be in place. I just want to mention a couple kind of quick things at the end. This is a modeling exercise, of course, and modeling is always an oversimplification, a gross over, not gross, but a wild, not wild, a very, a large oversimplification of what happens in real life. And we, really tried to approach this work in a way in which anytime we were making analytic decisions or assumptions, we tried to be as conservative as possible. And so I really do, believe that our results serve as like floor or minimum estimates for these potential impacts. There are many things that our team talked about that it's just going to be so hard to know how it's going to unfold, and we like couldn't really capture or include in our model, right? So I'd said we modeled the impact of new infections that occur during childhood in a single annual birth cohort of infections. We didn't model infections that would occur in adulthood if there are a larger number of children transition into adults that have not received the three-dose series and remain unprotected and experience all those risk factors for transmission in adulthood. We didn't model um, the impact on future cohorts as we move forward in time. If the number we all, are familiar with infectious disease here, if the number of infections, prevalent infections increase, we would expect our risk of transmission inputs to increase over time, and all of these results would continue to accrue over time. There are all kinds of implementation pieces of this recommendation that I think many people on this call are, could speak much more accurately to than I could. But our group talked about just challenges with like, if we're delaying vaccination, would clinical best practice then be to screen children before starting vaccination, particularly if it had been delayed further out? If so, those would be additional costs that we didn't include here. Is there concern that like, places where a lot of births happen, if vaccination is not recommended for as many children, would they be less likely to carry vaccine? And does that establish barriers for people that want it? So just kind of lots of different potential implications that we didn't include in this model that I think will be important. Um, so I imagine most people probably saw in the news, but this committee, met and they did vote to change the recommendation. The voting language is kind of confusing, and even they had challenges understanding it. But they essentially voted to, the voting language says something about using shared clinical decision making for infants born to birth parents who test negative for hepatitis B. And if they do decide to get vaccinated, it's not recommended to happen before 2 months. And then there is a different voting language that involves like testing for titer levels, which is a whole different conversation that we didn't necessarily model here. But um, I think it's important to highlight, and again, I think a lot of people here can speak much more strongly to how or if this plays out in Oregon. But it's important to highlight that, pretty much all professional medical societies have come out and said they disagree with this conclusion. They disagree with this process at which it was arrived at. I put here, the West Coast Health Alliance, yeah, which Oregon's part of course, immediately after the vote put out this statement about how they don't agree with this and they continue to recommend the universal birth dose. And so it remains to be seen exactly from a structural level how it might play out here in Oregon. However, I do think at minimum, it's created a lot of attention and a lot of conversation and a lot of confusion among parents, potentially among clinicians, about what is the best recommended path forward here. Even just following the news in the media and unfortunately, like the federal agency press releases, they're already starting to get confused around this idea of shared clinical decision making and 2 months, and it's starting to look like it's just automatically recommended for being pushed out to 2 months and losing that shared clinical decision making piece. And so, um, outside of the state law impacts that might happen around the country, I think just the existence of this conversation and being such a loud conversation over the past couple weeks is something that we all need to be thinking about because there's a lot to think about how it's going to unfold. Here is just a thank you and some contact information for everyone that I worked on this with. Yeah, I'll go ahead and stop there and say thank you. I believe doing questions at the end.
Hey, this is Ann Thomas. I'm just going to jump in with a little comment. It's great to see you, Eric, and I can't tell you how much I appreciate the timeliness of this analysis. And I think it's really crucial that the beauty of your analysis is that you didn't just include the effect of, well, if we didn't, vaccinate the kids whose, moms were known to be positive, because there's so many things where this can go, like this can just fall apart when we have sudden abrupt changes. And I actually went back and found a paper that I published like in 2001, because in 1999, maybe you, because the fact is we've done this just 25 years ago where we had a big change in the birth recommendations. And what happened, it was fear of thimerosal that led the AAP and the US Public Health Service to publish a recommendation that will just hold the infant dose in, except for the kids whose parents are known to be, or whose mom is known to be positive. And, it'll be fine. Yeah, it'll be fine. It, and it wasn't. I mean, I think there's national data how just vaccination fell apart, and most hospitals that had routine standing orders dropped them. And I think there were a few cases where, there was transmission because, like, the child of someone known to be positive didn't get it. But the big thing was, I mean, it just fell apart for everybody, but in particular, it fell apart for the kids whose birth parents had unknown Hep B status. And I think we looked at records of, because we had the electronic birth certificate, and we reviewed charts in about two-thirds of the hospitals in the state. And of the women who had unknown birth status, we found that in the 3 months prior to the joint statement, 80% of them had gotten their birth dose, like before hospital discharge. In the 3 months following the announcement, it fell down to 2%. And a year later, when thimerosal-free vaccine was widely available, it had gone back up to 4%. And then I forget the numbers, but then we then tracked these kids in alert. Thank you, IMI. And found that the ones who like had, these kids born to birth parents whose status was unknown, not only did they not get their birth dose, but they're, completing their 3 month, their 3 dose infant, first year regimen was much delayed as well. So it's like, I mean, I think people who don't understand our healthcare system, and then the other thing too is like inequities. Surprise, surprise. The women whose status was unknown, it's largely because they didn't get prenatal care, and it's, uh, disadvantaged, parents, and it's like people just don't get that. So it's great to have this data so we can kind of, I mean, it really transfers to like recent history in this country. I think it's something we can use. I'll send out the paper. But thank you again so much.
Yeah, just thinking that looking at employers that need to provide Hep B vaccines, so all the health systems, and you don't have people consistently getting Hep B as children, then employers are then required to provide that vaccine, which actually ends up being a high cost. So you have this larger group of health system employees coming in that need the Hep B vaccine. That is an expense that you could even factor into this. It's not really a question, it's just another, OSHA requirement for anybody that's around blood, or first responder, anything will all be required as adults to get it, and the employer's stuck with that cost.
That's a really good point. So I think if mine is a little harder to my understanding, I think you're saying is, if fewer people are getting vaccinated as children, when they go and hit a point where they're working and there's employment requirements to have the hepatitis B vaccine, then the employers then carry that burden of paying for those vaccines there. Yeah, and that's an excellent point. That's not something that we included in this, and that's another good example of just so many potential downstream impacts and consequences that I wish had been more given more conversation and consideration during these deliberations, honestly.
Thank you, Eric. Hey, this is Ann Chapman. Can you hear me okay?
Yes.
Great. Rex, this might be a question for you and or Eric, or any of our other immunization program staff on. Since ACIP recommendations are the backbone of the Vaccine for Children funding criteria for specific vaccines, how does this impact Vaccine for Children hepatitis B vaccine coverage?
Yeah, that's a great question, Anne. My name is Rex Larson. I'm the surveillance and quality manager with the immunization program, and I'm part of a group at OHA that works with both Medicaid and DCBS to try to figure out both the legal and the financial implications of these sorts of changes. In this case, you know, uh, of all the votes we thought could happen at the ACIP, this was sort of in some ways the best case scenario. And the reason is twofold. One is that it kept the recommendation at 2 months, which I think is a probably decent timing if you're going to eliminate the birth dose. And the second is that it maintained that shared clinical decision-making piece. And that's really key for the financial aspect. That means that Oregon can maintain a universal birth dose recommendation, which we did by participating in that West Coast Health Alliance recommendation. And we can still maintain VFC access and pay for it through Medicaid. So there's a lot of complexity. I think one thing providers should not be concerned about is coverage. We have structures in place in Oregon to maintain private coverage for birth dose Hep B and VFC coverage for birth dose Hep B. So right now in Oregon, the recommendation stands. Everybody should get a birth dose and everybody should have coverage for it. There are some employer self-pay plans which are voluntarily covering it, and we don't have regulatory authority to enforce coverage on, but we're working on that as well. Most of them are still paying for it though. So if anyone hears of anybody not getting coverage for it, we'd love to hear about it.